This is the 10th presentation of the American College of Cardiology Video Seminar Series on echocardiography. The topic is cardiac masses and includes a discussion of cardiac tumors, thrombus, and vegetations. The topic of artifacts and masqueraders pertinent to the discussion will also be illustrated. Confident, non-invasive visualization of masses and clots within and about the heart are a unique and often superior attribute of two-dimensional echocardiography. This tool has revolutionized the diagnosis, understanding of pathophysiology, and management of cardiovascular tumors, thrombus, and vegetations. In the 1960s, M-mode echocardiography first permitted non-invasive diagnosis of some cavitary tumors, in particular the atrial myxoma. However, this technique did not appreciably impact on the necessity for confirmatory cardiac catheterization. In the 1980s, two-dimensional echocardiography, and more recently transesophageal echocardiography, as illustrated in this example, have become the imaging procedures of choice and a substitute for conventional angiography in most circumstances. The following discussion will review the two-dimensional echocardiographic diagnosis of cardiac masses. There are usually recognizable anatomic features which set each diagnosis apart. This first segment will deal with primary and secondary tumors of the heart. Primary cardiac tumors are listed on this slide. They can be divided into benign and malignant forms. The most frequently encountered benign tumor in the adult is the atrial myxoma. In childhood, the rhabdomyoma. The most frequently encountered primary carcinoma of the heart is the angiosarcoma. This first example is a classic left atrial myxoma in a 44-year-old female. In this apex down format, the left atrial cavity is filled with a mass. Note that this mass lesion is attached to the atrial septum near the valve of the fossa ovalis and prolapses through the orifice of the mitral valve with each diastole. This typical attachment and motion is near pathognomonic of atrial myxoma. This is another example of a classic atrial myxoma, which is diagnosed only on transesophageal echocardiography. The transducers in the esophagus adjacent to the left atrial cavity. Note that there is a small tumor confined totally to the left atrial cavity and attached to the valve of the fossa ovalis. In the sagittal plane, with the transducer adjacent to the left atrium, note that this small pedunculated atrial myxoma is attached to the valve of the fossa ovalis. This is an example of an atypical tumor in a 32-year-old man. Note that the left atrium in this peristernal long-axis view is filled with tumor. The mass prolapses through the orifice of the mitral valve and has many of the features equated with left atrial myxoma. In such examples, multiple projections should be obtained. Here, in the short axis scan from left ventricle toward the orifice of the mitral valve, note that the tumor is oriented laterally and in fact does not insert on the atrial septum. The fact that this tumor does not insert in the atrial septum should alert one to an atypical presentation. In fact, this is a metastatic osteoblastic sarcoma. Note as the scan is carried back down through the atrial cavity that it distinctly arises from a lower lobe pulmonary vein that is not attached to the atrial septum. One should always be wary of masses not attaching in a typical manner characteristic of atrial myxoma. This next example is that of a syndrome myxoma in a 45-year-old woman. These patients are typified by having excessive freckling, note around the eyes and on the mucous membranes. These patients have recurrent atrial myxomas. This is a peristernal short-axis scan of this same patient. At age 35, she had a right atrial myxoma. At age 43, a left atrial myxoma. And now at age 45, a question of a small pedunculated mass in the right atrium. Note that on this peristernal scan, the tumor is not adequately elucidated, and thus transesophageal echocardiography is to be performed to further delineate this questionable recurrent atrial myxoma. On the transesophageal echocardiographic examination, the transducers within the esophagus and adjacent to the right atrial cavity, note that there is a small pedunculated ovoid mass in the free wall of right atrium. This is an atypical insertion point for an atrial myxoma, but very much consistent with the atypical recurrent nature of the syndrome myxoma. This particular patient has had 7 recurrent atrial myxomas and has required 3 thoracotomies. The next example is a classic right atrial myxoma in an obese elderly male. The transesophageal examination best elucidated the cardiac tumor. In this case, notice that the mass is pedunculated and inserts at the valve of the fossa vallis, characteristic, if not pathognomonic, of an atrial myxoma. Note that the mass prolapses through the orifice of the tricuspid valve and nearly fills the total right atrial cavity. The next atrial myxoma is that of a dumbbell myxoma in a 70-year-old male. Note that an ovoid tumor bridges the plane of the atrial septum, as illustrated by the arrow. This type of myxoma prolapses through the valve of the fossa vallis and appears to bridge the plane of the atrial septum, and thus is frequently termed a dumbbell atrial myxoma. The next most frequently encountered benign tumor is the papilloma or fibroblastoma, which is a small pedunculated finger-like mass found on the endocardial surface of atrioventricular valves or ventricular myocardium. This is an example of a fibroblastoma in an elderly woman with amyloid heart disease. Note on this peristernal long-axis view that there is a small pedunculated mass in the left ventricular outflow tract. In real time, the mass has an undulating motion, often described as a sea anemone in appearance. Other features on this echo, of course, are those consistent with extensive amyloid heart disease, the hyperrefractile myocardium, the thickened myocardial walls, and pericardial effusion. This is an apex-down, long-axis view of the left ventricular outflow tract in the same patient. Notice the hyperrefractile pedunculated mass in the left ventricular outflow tract. This small undulating tumor is very characteristic of the fibroblastoma or papilloma and is a benign tumor, rarely exceeding 1 centimeter in diameter. The second example of a papilloma is in a 67-year-old female. The tumor was best elucidated by transesophageal echocardiography as a 1 by 1 centimeter mass attached to the tricuspid valve. Note that in real time the mass has an undulating motion characteristic of a benign papilloma. These benign tumors rarely exceed 1 by 1 centimeter in size and infrequently need surgical attention. This is an example of atrial septal lipoma, or lipomatous hypertrophy of the atrial septum in a 70-year-old male. This is a subcostal 4-chamber plane of section. Note that the atrial septum is markedly thickened, with sparing of the valve of the fossa vallis. At the base of the septum, the thickness appears almost tumor-like. This condition is usually benign, although the amount of atrial septal hypertrophy may be quite excessive, but should not be confused with malignancy, atrial myxoma, or other more serious conditions. This is another example of lipomatous hypertrophy of the atrial septum in a 50-year-old man, best elucidated by the transesophageal approach. Notice the typical dumbbell appearance with sparing of the valve of the fossa ovalis. This dumbbell appearance to the atrial septum is nearly pathognomonic of atrial septal lipomatous hypertrophy. This is not always equated with a fatty body habitus and is a benign condition rarely associated with significant supraventricular arrhythmias. This is an example of a benign fibroma of the left ventricle in a 20-year-old male. Note that on this parasternal long-axis view, there's a hydrorefractile ovoid mass in the posterior wall of left ventricle. These tumors are not encapsulated, but frequently appear as a well-circumscribed hydrorefractile mass, usually embedded in the myocardial wall. When small, they're usually benign, although have been associated with arrhythmias. When large, they can be excised surgically. This particular mass was found incidentally in an otherwise healthy young man. This is a short-axis left ventricular scan in the same individual. Note that the ovoid mass is adjacent to the posteromedial papillary muscle. This well-circumscribed hydrorefractile mass is characteristic of a benign cardiac fibroma. It is unchanged in size for over 3 years and thus is being observed. Larger impinging masses frequently are surgically excised. This is a 6-month-old female with tubular sclerosis and multiple cardiac rhabdomyoma. On the parasternal long-axis scan, there's a pedunculated tumor in the apex of left ventricle and multiple tumors found in the right ventricular cavity. The rhabdomyoma is the most common benign tumor found in children. It is most frequently associated with tubular sclerosis. The tumor can be variable in size. When large, it can cause inflow or outflow obstruction. Also, as the child grows older, the tumors have been known to regress in size. This is a short-axis scan at the level of the aortic valve in the same child. Note that there are masses visible in the right ventricular outflow tract. In real time, some of these masses appear to be pedunculated, while others are fixed and sessile, and yet others appear to be embedded in the myocardium. This is a typical spectrum of the benign rhabdomyoma of childhood. This is another example of rhabdomyoma in a 7-month-old female with tubular sclerosis. On this parasternal long-axis view of the right ventricular inflow, note that there is a large laminated mass in the right ventricular apex. This highlights the variable presentation of the rhabdomyoma in childhood. The most commonly encountered primary malignancy of the heart is angiosarcoma. This is a 31-year-old male who presents an acute cardiac tamponade. The pericardial effusion was grossly bloody. Note that the swinging motion of the heart suggests cardiac tamponade. These tumors are usually found in the atrial wall, in the pericardium, and compromise the inflow portions of the ventricles. They're usually incidental findings after this initial presentation of cardiac tamponade. The tumor is extremely malignant, and death usually occurs within a few months after diagnosis. Note in this example that the cardiac chambers are compromised. The swinging motion of the heart is typical of tamponade in a young man. This is a precordial examination in the same patient following pericardiocentesis. This is in the apex up format, and notice that in the right atrial free wall there is a mass. This is a typical presentation of angiosarcoma. This young man subsequently underwent cardiac exploration and partial resection of the tumor. However, it had extensively spread, and the young man died within 6 months of metastases. The presentation of cardiac tamponade, bloody effusion, and subsequent atrial tumor is typical of angiosarcoma. Secondary cardiac tumors of the heart are usually malignant and are either metastatic to the heart or enter the heart through the cava or pulmonary veins with extension into cardiac chambers, or are adjacent to the heart, either in the mediastinum or pericardial space. The tumor which most frequently metastasizes to the heart is the melanoma. However, in frequency, bronchogenic and breast carcinoma are more common. This is a 51-year-old female found to have a large mass in the posterior wall of left ventricle. She'd had a melanoma removed from her great toe a number of years previous. Note that there is a hypolucent mass in the posterior wall of left ventricle beneath the posterior leaflet of mitral valve. Note that this ovoid mass is relatively hypolucent and is not hyperrefractile, which would be more characteristic of a fibroma or lipoma. Other echocardiographic views are necessary to characterize benign versus malignant. On short-axis scan at the level of left ventricle, the tumor is clearly visible behind the left ventricular posterior wall. More importantly, the tumor mass appears to be incorporated into the myocardium and actually in the ventricular septum replaced the myocardium and is typical of a metastatic tumor. With scans toward the base of the heart and apex, this distinction of malignant versus benign nature becomes more evident. On closer examination of short-axis scans of left ventricle, note that this mass is incorporated into the myocardium, particularly along the ventricular septum. This is very characteristic of a malignant metastasis to the heart and is very characteristic of malignant melanoma. The hypernephroma and hepatoma typically migrate to the heart through the inferior vena cava, while pulmonary venous extension is more typical of lung and mediastinal tumors. This is a 62-year-old female who presented with vague cardiac symptoms. She is found to have a large mass filling the left atrial cavity and partially prolapsing through the orifice of mitral valve. Note that the mass is ill-defined and not well delineated by this precordial long-axis view of left ventricle. To further elucidate the nature of this mass, transesophageal echocardiography was performed. Note that there is a large solid mass of the left atrium and an extension of this mass thought to be thrombus prolapsing through the orifice of the mitral valve. Note that this solid tumor mass fills the majority of the left atrial cavity, while the thrombus extension prolapses through the orifice of the mitral valve. On closer observation, the tumor appears to be fixed to the atrial septum or posterior wall of left atrial cavity. Diligent search reveals that the tumor extends from the right upper pulmonary vein and extends through the vein from the mediastinum, in this case, a metastatic mediastinal melanoma. With color flow Doppler on, blood appears to percolate around the stalk of the tumor, which is growing out of the pulmonary vein. Inferior caval extension of tumor is typical of the hepatoma or hypernephroma. This is a 60-year-old male with a hepatoma which has migrated up the inferior vena cava to produce a filling mass in the right atrial cavity. Note that this mass occupies the right atrium. It is important to further elucidate the origin of this tumor by visualizing the inferior vena cava. This is a subcostal long-axis view of the inferior vena cava in the same patient. Note that there is an ill-defined mass filling portion of the right atrial cavity, and that the inferior vena cava appears to be filled with mass, in this case a hepatoma, which has migrated up the inferior vena cava to fill the right atrial cavity. This is a typical appearance of malignant extension of tumor from the cava. The lymphoma is the most frequent anterior mediastinal tumor, while breast and lung carcinoma frequently involve the pericardium. This is a 24-year-old male with a large anterior mediastinal tumor, typical of a lymphoma. Anterior to the aorta and the pulmonary artery is a large, ill-defined mass. The anterior mediastinal position of the tumor is very typical of lymphoma. Note that the mass is large enough to partially compromise the right ventricular outflow tract. In some situations, the tumor can, in fact, become large enough to compromise the pulmonary outflow tract, causing pulmonary stenosis. The anterior position of this tumor is very typical of a malignant lymphoma. Other more rare anterior mediastinal tumors would include the thymoma or other malignancies. In this same patient, the suprasternal examination highlights the extensive nature of this anterior mediastinal tumor mass. The aortic arch is displaced far posterior, and the brachiocephalic vessels appear to be elongated and stretched. The tumor mass extends far up into the upper mediastinum and partially compromises the brachiocephalic vessels, the aortic arch, and the pulmonary arteries. This was an example of a large lymphoma of the upper mediastinum. This is a 65-year-old male who was found to have an incidental cystic mass posterior to left atrium on routine precordial examination. Note that the mass appears ovoid and posterior to the left atrial cavity. The descending thoracic aorta is visualized as a separate structure and is not confused with this cystic appearing mass. This particular structure could not be completely elucidated by precordial examination, thus transesophageal echocardiography was subsequently performed. On transesophageal examination, the transducer lies adjacent to the left atrium and to a cystic mass outlined by the arrow. The pulmonary veins, the right lower pulmonary vein and the left lower pulmonary vein, appear to be distorted by this cystic structure. In real time, the mass has an undulating appearance and irregular consistency and was most typical of a bronchogenic cyst which compressed part of the left atrium but did not appreciably distort the right pulmonary artery or the other mediastinal vascular structures. With further superior scanning, in fact, the right pulmonary artery, is exemplified by this arrow, is not compressed, nor is the aorta or superior vena cava. To better elucidate this cystic structure, a prototype wide-field transesophageal echocardiographic examination was performed. This is a 360-degree scan highlighting the descending thoracic aorta, vertebral body, and large cystic mass. Note that the mass appears as an ovoid structure. It compresses the upper pulmonary veins and distorts them slightly and produces minimal compromise on the left atrial cavity. This new imaging modality is most intriguing application of esophageal echo.